Good afternoon. Good afternoon, everyone. Good afternoon, everyone. I would like to thank AIOS and Shweta for having me here. So I make a very profound statement when I tell about trabeculectomy. It's a surgery I do because I have to do, not because I want to do. It's why because you do end up with many Bleb challenges. Well, what is trabeculectomy? Basically, you're just making a connection from the anterior chamber to the subtenon space, which causes an alternate pathway for the drainage of aqueous. So, what does this finally lead to? Does it leads to, since there's an alternate pathway, you have another way where the aqueous can drain out. So it all depends on your conjunctiva, how the fibrosis occurs, because this determines the hydraulic conductivity and controls the fluid flow through the tissue. So if you have IOPs of around 10 to 14, it is associated with minimal fibrosis, and we know that it lowers visual field deterioration. So what is an ideal bleb? Well, you could have one which is functionally ideal, you could have one which is structurally ideal. So functionally ideal is one which lowers pressures to a target range. And what about morphologically? Is it really important? Well, there are many factors which are associated with it, but what would a perfect bleb be? One which is diffuse, has microcysts, is mildly elevated, and has a few blood vessels, though with a little paucity of vessels and moderately thick. So, well, is this a good bleb? Well, more or less, yes. You never know when because these blebs do change over time. So, what happens to the aqueous which comes in these blebs? They go through the conjunctiva, they mix with the tear film and are absorbed by the vascular and perivascular conjunctival tissues. But well, you can have scarred blebs like this and still have normal pressures. How? How do you explain this? Well, this is because of the new incorporated aqueous veins, the normal aqueous veins, and the lymphatic vessels near the scarred margins of the surgical area, which help drain the aqueous and reduce the pressures. Well, there was this study in current opinion, this review article in Current Opinions, which looked at various parameters as to what would actually change the outlook of your trabeculectomy, and they found that others would, but type of a scleral flap, whether you made a square, rectangular, triangular, what the size of your stoma was, or whether you maintained the anterior chamber with air or saline or viscoelastics or what, didn't have any effect on the final outcome. So, following a Bleb surgery, you do have various factors, which include the pre-op risk factors, the bleeding intra-op, the release of different growth factors, all of which could finally affect the outcome of your Bleb. We do use mitomycin more than anything else and a lot of steroids, sometimes non-steroidals, to help make our Blebs look good and function well, both morphologically and functionally. So we do know this chart about what our early post-operative complications are. We do know that too low pressures are more challenging, and what our early complication of a shallow anterior chamber with a bleb leak is probably the one which we need to be most careful and prevent this from happening. So early bleb leaks, these occur because of either buttonholes, suture tracts, or leaks through the conjunctival edge. Very rarely do they lead to a shallow or a flat anterior chamber, but we do know that any leak in the early postoperative period can increase the risk of failure. So yes, so we need to prevent it. We need to make watertight closures while we are doing the surgery. We need to, because we do have sutures there, we need to tell the patients you should not wipe, should not specially wipe. If you feel there's something there, you just mop, put your tissue and come out, don't wipe it. If there are loose sutures or a suture tract, you need to remove it. And also see, sometimes using NSAIDs or atropine, you could have drug allergies. The conservative treatment, well, you could just patch the eye, use a bandage contact lens, You could use aqueous suppressants, antibiotic drops like gentamicin, which increases fibrosis. And there have also been reports of using oral doxycycline because of its anticollagenolitic properties to inhibit the matrix metalloproteinase. The other, if this doesn't work, then we'll need to take the patient in and do resurgery. So the second is an overfiltering large bleb. So in this sort of a large bleb, you can see there are a few corneal folds. The AC is moderate. Well, in this, you just need to increase the steroids. Very rarely do you need to intervene into these, the more so when there is an iridocorneal touch, where you'll need to do a AC reformation with Helon and air. If there is an excessive leak through a scleral flap, then you'll need to resuture the flap. And if there are choroidal detachments with kissing choroidals, you'll need to drain these choroidals. The next is this, the ones where you're having corkscrew vessels, which is more a sign of that it's failure or a subconjunctival hemorrhage. When this is a flat bleb and a high IOP, so if there is a tight closure of the flap, you'll want to teach the patient to do a digital massage, release the suture or do a suturolysis. If there is a scarring of the episcleral surface, you'll want to give 5-FU injections, and you'll obviously want to do a gonio to see if there's any obstruction in the stoma, and if that is there, you'll need to remove it. For example, this patient, he was a young uveitic patient and he had a subconjunctival bleed, but we did give him 5-FU, and this is his bleb at 3 months. The next is the encapsulated bleb. Well, this is seen in around 8.3 to nearly 30%. It's seen between 2 to 4 weeks after surgery. It is tense, elevated, smooth dome. So in these patients, basically what you have to do is just tide over the phase of around 2 to 4 months when it will spontaneously resolve. So you give glaucoma medications, reduce the intraocular pressure, allow the remodeling of the cyst wall, also teach the patient digital pressure and increase the steroid therapy. It's only when the intraocular pressure is not under control would you want to resort to either a bleb needling or a surgical revision. In late bleb leaks, well, the treatment is mainly surgical, where you'd want to do a conjunctival advancement and a transplant. In dysmorphic blebs like this, you will need to do an excision, though very rarely, if it's mild, you can give lubricant eye drops. Another dreaded infection, dreaded complication is a blebitis. Well, in this, there are various risk factors, and blebitis can lead to endophthalmitis and loss of eye. Well, to conclude, we need to look at future directions where we could modify the bleb architecture to decrease bleb complications. Well, obviously, a no surgery alternative is best, so probably newer drugs like netrosudil and triposudil or rokinase will work. We could think of other celioablative techniques which would work, and probably non-surgical techniques which will be dealt with soon. Thank
Thank you,
you.
Vineet sir, for such a beautiful presentation and making everybody bleb friendly instead of getting scared of the leaking bleb or I can say overfiltering bleb. Definitely now we are much more aware that what we have to do in time. And just requesting Dr. Dilip sir to give a brief bottom line from this talk, the bleb challenges, since he's the discussant. And in the meanwhile, I will request, yeah, Dr. Vinita is there.
Thank you, Dr. Vineet. It's a good presentation. Nicely elaborated the blab failure and prevention of failure. And blab leakage is the most common problem, which should be controlled in otherwise. And first of all, blab, if failing, that you should take the leakage test and then it should be controlled otherwise. And I will have some query for Dr. Vineet, if I can ask.
Yeah, please.
If you are using mitomycin C, so what is the timeline you should remove that mitomycin C? So it's releasable suture in cases of mitomycin C, if pressure is otherwise controlled, like below 10.
If the pressures are controlled, I don't remove, I just trim the
trim inside the blab.
Yes, that's at the final checkup around 4 to 6 weeks.
4 to 6 weeks. Okay.
I think also, sir, to correct me if I'm wrong, at that point when you're judging whether to trim or to remove the releasable, and when I say this, I mean beyond 3 weeks, do you also do a digital massage and see that if the IOP is not coming down at all, then maybe pulling it off is also not a bad idea. If the IOP, however, drops down with aggressive digital massage, then maybe trim it. That's just a way to cross verify whether what you're doing is right
Yes,
or not.
yes, absolutely. So if you want lower pressures, so we were talking about 10 pressures and lower. So if the pressures are high, you would first want to do a digital massage, check how much the pressures are low, and then pull out the.
Even
Do a
this,
gonio before that.
yes,
You want to always check whether your ostium is patent or not.
and
Sorry.
even this could be a deciding factor for doing your ALS also. You do a digital massage, you see that your bleb is elevating, then probably you can decide for your ALS also. That is after you have removed the releasable.